And I welcome everyone to the April 22nd, 2026 Grand Rounds. And it's going to be a great day because Dr. Hussein Tariq, our illustrious treatment planner, prosthodontist, and clinical director at ITX Pros, told me we have some outstanding cases. So looking forward to doing that. As always, we have our Dr. Robinette, who is online, who will answer any of your questions. If you have any of your questions, just go right to the chat and put your question in, and he will get right back with you. With that being said, as you know, I always start off with a quick little lecture on a controversial topic or an interesting topic. So today, what I'd like to talk about is an interesting case to where it actually happened this past weekend at our course on what should be done in this case. A doctor was going to restore this implant, and basically this is the x-ray that he found that he had taken approximately 4 months after the implant was placed. And as you can see, it does have crestal bone loss. So what is the problem? Well, it's 4 months after the implant placement, and the doctor was very astute to say, should I actually do this? Because with that amount of bone loss, is it a good idea? Medical history, the patient is a diabetic. He did not have a current A1C, but he thought the patient was controlled. With that being said, I have a couple questions, and I'm going to go over the questions and the answers. So why would you lose bone right after you place an implant and during the healing phase? Meaning, why would you lose over 4 millimeters of bone circumferentially around an implant? The majority of the time, the reason that is because you don't have the vision A bone when you're placing the implant, meaning there's not enough bone on the buccal and on the lingual. We know when we place an implant, we want to have a good 2 millimeters on the buccal, 1 on the lingual for successful healing. We know that once a tooth is extracted, the bone resorbs from buccal to lingual, and a lot of times we have division B bone, which does not allow us to place the implant with that amount of bone on the buccal and the lingual. So what happens during those 4 months? Because the bone is so thin, lack of blood supply, the blood supply we're only getting it from the periosteum, usually that bone will start to resorb, and most likely that's what happened in this case. Other possibilities is a surgical error. Force related always comes up as a possibility, but as you can see they did a stage 2 here, so they only put a cover screw. There was no abutment placed, so the patient really couldn't put any force on it. And hygiene, that always comes up also, but very rarely would that ever happen, or even that be a possibility, because it wasn't restored. It was under the tissue. So I doubt that. My thought on it was it's a treatment planning error. Mainly there wasn't enough bone to start with in width. Number 2, what are the treatment options? And that was this doctor's question. What do I do? If I look at this x-ray, you can see here a radiolucent area right apical to it. So I think what also happened here is they might have drilled their osteotomy a little too deep, or they possibly didn't place the implant deep enough. They did tell me that their post-op x-ray showed bone right to the crestal top of that implant. So, but whatever happened there, it did look like they did drill a little bit deeper there. So what is our first option? First option is to restore the implant. Now, that's not a good option. Why isn't that a good option? Because if you try to restore an implant with 4.5 millimeters of bone loss circumferentially, if you have bone loss before the implant is in occlusion or prosthetically rehabilitated, that is going to only worsen, and you're going to lose more and more bone. So I don't believe that restoring the implant like this is ever a good option. Option two would be to restore the implant and just graft the threads. So what's the problem with that? Well, if you restore the implant, expose it, and graft it, and then place a crown on it, first of all, you're going to put a lot of force on it. So that's going to be questionable if the force is going to destroy any bone regeneration possibility. Secondly, you have to decontaminate all these threads. There is a biofilm around all these threads because it's been exposed to the oral cavity. So to, again, get bone regeneration around contaminated threads is very, very questionable. And then third, remove the implant in immediate placement. And I know doctors always want to do this. And I always ask, first of all, is the implant mobile? If the implant is mobile, that means you have soft tissue in there and you're never going to want to replace it unless you can put a wider implant. Now, it's most likely, again, we didn't have enough width, so I doubt that would even be a possibility here. If you look at a cross section of this case on what the implant would look like if you would place it after you take the implant out, getting primary stability is going to be a problem. It's going to be a very, very short implant, and it's going to be very questionable if you can get even primary stability. Or if you go even longer, you're going to perforate through the lingual plate, which is not good, or you're going to get into the canal or the frame in there and cause a problem. So treatment plan 3 is not a good idea. Leaves us with the last, and that is to remove the implant and either go with a conventional prosthetic treatment plan or graft it and delay a future implant placement. Now, what is the positive about that? Well, you're going to remove the implant, graft it, and allow that to heal. So now you're going to be placing another implant basically in the virgin bone, higher success rate. So we know that the pH of that bone is going to be a lot better. It's going to be more conducive to remodeling and osseointegrating. So that leads me to the last question. How do you remove this implant atraumatically? Well, first of all, if you look at an implant removal, if it is mobile, if you have in the red here is soft tissue, if you have red around an implant, that means that it will be very easy to remove because there is no bone integration in the implant. A more challenging technique situation is when we have green here, which is bone that is integrated into the implant already. So it's non-mobile. So in this case, if we take out a non-mobile implant, in the maxilla, it's a lot easier because the bone quality is inferior to the mandible, where it's a lot better with cortical and cancellous bone. But that doesn't mean that we shouldn't try in this situation. So what I told the doctor was there's 2 ways to remove it conservatively. One is reverse torque, and 2 is the screw extractor. So let's talk about that. The first technique is basically you put the same insertion tool into the implant. And instead of ratcheting the implant deeper, you're going to reverse torque it. Indications when there's no damage to the implant and there's minimal cortical bone. When there's minimal cortical bone, which we have in the maxilla versus the mandible, it's very easy to remove these with the reverse torque. So you place insertion tool or the driver, you use your torque wrench backwards, counterclockwise. Usually you'll just feel like a little pop and it will free up and you'll be able to loosen it out. So that's the easiest way. A second way is with a screw extractor. And what is a screw extractor? It is a special tool that basically has a reverse thread on it, and you thread it into the implant. So you thread it in counterclockwise, and this is from the Salvin Rescue Kit. So you screw it in counterclockwise because of the reverse thread. What will happen as you torque it in, it will actually cold weld. So it will cold weld to the implant, And then what will happen as you continue to auto reverse it or reverse torque it, it will just break free and remove it. Now, in some mandibular cases, that will not work. So you have to use those two techniques in combination with one of these three. And the first is a trephine burr. A trephine burr is a barrel burr, and basically they fit over top of the implant, like you can see right here. And you use a pumping motion with a lot of irrigation. I like these over here on the right. They have a big window in them, so you can get very good irrigation, because the tendency with the trephine is to overheat the bone, which is the last thing that you want to do. Another technique that you can use is a 700 XXL or an XXXL, which is a extra long. These are surgical taper burrs, so they go in a high-speed handpiece, and they're crosscut fissure burrs, and they will remove the bone around the neck of the implant. And basically, by removing bone around the neck of the implant, you just keep removing bone until you loosen that implant to where you can auto reverse it out of the jaw. And then the third works very well also. This is a piezoatome, so it's piezo surgery. This is the cube, and it's made by Action. Works very, very well. And you can go, they have certain inserts that are made to extract teeth, also to remove implants. And what is good about this is even though it does a little bit slower, it works very atraumatically, and it's very successful in getting these implants out. So those are the different techniques. So in summary, be very, very careful. You never want to just restore an implant with that much bone loss. Now, maybe if it had 1 or 2 millimeters, then you could possibly graft it. That is more in a greater prognosis. However, not in a condition like this. Restore the implant and graft. I think what you're doing is kicking the can down the road. You're going to end up removing the implant. Secondly, you're going to waste a lot of money in grafting, restoring the implant, and then having to redo it. Immediate replacement is not always the best way to do it, especially if you have anatomic structures that are going to limit you. Then ideally, remove the implant, graft it, delay the implant placement, and then place the implant in a more ideal position after everything has healed. So this is an interesting case. If you have any questions, go ahead, and Dr. Robinette is ready to answer any of your questions. And with that being said, let's get to Dr. Hussein, who has all the good cases, and let's go for it.
Thank you, Professor. It's always a pleasure being here at the Resnik Institute. The first case we got for today is for Dr. Pham. Dr. Pham, would you mind unmuting yourself and presenting your case to Professor Resnik?
Hi, Dr. Pham. How are you?
I'll ask Dr. Pham to unmute, Professor. I'm sorry, give me a second. Dr. Pham, ask to unmute.
Dr. Pham, are you there?
I think he's there. He's on the list, Professor, but if you wouldn't mind, I could go to the next case and we
Yeah,
can
let's
discuss.
just go to the next case and we can come back to him.
You got it,
Okay.
Professor. So next case is for Dr. Poco. Dr. Poco, would you mind unmuting yourself and presenting your case to Professor Resnik, please?
Hi, Doc. How are you?
Uh, Hi. Thank you
Hi,
for
how are
taking my
you?
case.
Okay,
So,
good. So what do you have for us tonight?
okay, so I have to apologize first of the quality of the CBCT. My assistant took it and I didn't look at it, but I needed to send
Okay,
it in.
no problem.
So
No
I have
problem.
this patient who's been coming to me for a while. She had a failed tooth number 11. She said she couldn't afford it, so she went to Bolivia, I think, and had it done. Now she was gone for maybe 6 weeks, and within the 6 weeks, they extracted the tooth, they grafted bone and placed the implant and restored it. So when she came back, it was all done, and And she came with a note from her doctor to tell me to put her on antibiotic and to follow up and stuff and stuff. So it took a while for the implant to heal. It finally did seem to osseointegrate, but over the years, she constantly complains of facial pain, the pain in that area when she pushes her finger over the area where the implant is, and she sometimes feels feverish. She's febrile, and we took this, and I saw that her sinus too, the lining was thickened, and but I didn't know what to do. The implant seems displaced. It sticks out a little bit, but it's still non-mobile. It's pretty firm. So I wasn't sure. Was it her sinus? Is it the implant? I'm not sure.
Okay. So, Doc, first of all, Hussein, can you just give us some cross sections on this? Let's just take a peek at this and see what we're dealing with. Okay. So go ahead, scroll, and then if you can do a 360 for us.
I'll add just an implant on top of that implant to provide you with the 360 view, Professor. Here we go, sir.
Okay. So, okay, so let me just make sure I understand the situation. The patient, approximately a couple years ago, went to Bolivia, had this implant, had it restored, and now they're back in your office with chronic facial pain. And how
Yeah.
long has that facial pain been occurring? Has it been since they restored this
So
implant?
it was restored there before she came. So when she came, it was in the process of healing because it had just been maybe 6, 7 weeks and they got all the work done. So it was healing. So at that time, yes, it was sore. Then after a year, she said it felt fine. Then, maybe last year she started calling me and coming in for a limited exam because she was having pain in that area. She kept saying, I have pain in that area. And what I realized that she sounds nasal sometimes. So I kept asking her about sinus issues and stuff. But what was interesting was that she responded to augmentin anytime, like, because I thought that maybe there was something going on there, and she would respond to augmentin, and I'd ask her to see an ENT, but she feels like it's the implant because she says when she touches that area facially, it seems very tender. I spoke to her today. She says she feels a little better, but still very tender, and it's giving her shooting headaches and stuff.
Okay. Okay. First of all, Hussein, is that the most superior we can get on this?
Unfortunately, yes, sir. That was the field of view
I'm sorry.
captured by the doctor's
Okay,
CBCT.
that's all right. Uh, do you see that radiolucency? Is that possible? Could you trace that to see if that's a canalis sinuosis?
Um,
See where I'm talking there? See how?
ye-
Yeah.
it's
See right
definitely a
there?
canalis signosus, sir. Like this is the canalis sinos. Let's check it through the axial image, Professor. If you would allow me, sir,
Okay.
I'll just take a quick look
Doc,
at
just give
this.
us 1 second. Let me just see this
Okay,
before.
doc.
I don't want to give you incorrect information, but
There is a canalis signosus,
yeah.
Professor, but
So you know what this might be. Okay. So let's go back to the cross section.
yes, sir.
Then I'll give you my thought on this. So right off the bat, Doc,
Yes.
if this implant where it's located would not be causing a sinus, a maxillary sinus related
Okay.
issue.
Okay.
So this particular implant's in the canine.
Okay.
Now, what I am a little concerned about is, as you remember from the course, we talked about single maxillary canine implants. It's one of the most difficult implants to restore because you have a cuspid disclusion. So, how do you
Mm-hmm.
disclude on it in 6 weeks? That
Mm-hmm.
just seems like this is way over stress. So, that's one problem because
Okay.
there is bone loss. You can see
Mm-hmm.
circumferential
Mm-hmm.
crestal bone loss around this implant. Now,
Mm-hmm.
on a CBCT, it's not 100% conclusive on how much is there, but we
Mm-hmm.
can tell just from this x-ray that she
Mm-hmm.
definitely has bone loss. Secondly,
Mm-hmm.
uh, here is a couple tests that I want you to do. So I want you to see her back. And what I
Okay.
want you to do is press on the facial of that crown and
Okay.
push it lingual and
Okay.
see if that elicits pain.
Okay.
Or opposite, from the
Okay.
lingual, push it buccally.
Okay.
If she elicits pain, there's a good chance that this is a failure.
Oh.
Another option or another test that is even more conclusive is I want you to get your thumb and
Okay.
your index finger, and I
Okay.
want you to, on the buccal plate and on the lingual plate, I want you to squeeze together.
Okay.
And if you squeeze together and you don't feel bone and it
Okay.
feels fluctuant,
Okay.
so it's mobile,
Okay.
or if the patient has pain when you do
Okay.
that, and
Okay.
do it pretty hard, really
Okay.
compress it. If they
Okay.
have pain, then it's the implant,
Okay.
because implants are not innervated. There's no innervation to it. However, if it's fibrously encapsulated, meaning
Okay.
there's soft tissue around it, that there is innervation to that soft tissue and the inflammatory areas. So,
Okay.
with that being said, why is this failing, or why did it fail? Probably because they rushed it 6 weeks. They didn't understand. Anytime you're doing a cuspid implant, you want to disclude it right away so that you don't put too much shear force on it. This patient has all their natural teeth, most likely that. Secondly, do you remember we discussed the canalis soniosus?
I do. That's why I sent it to you because I wasn't
Yes,
sure.
yes. So what I'm seeing, and Dr. Hussein showed, I can't do it on my screen.
Yes, sir.
Dr. Hussein, can you just show them with an arrow where I was
Yes.
pointing to? That arrow right there? Okay. Right there. Okay.
Hmm.
So
Okay.
that's the superior aspect of it. I think
Hmm.
what happened
Hmm.
is when they put this implant in, that they probably did put it through the canal soniosus, which does give you this type of pain.
Hmm.
And probably it has become necrotic now because of the implant. So that's why you don't see
Okay.
the crestal or the apical end of that by the
Okay.
implant. But that is a canal soniosus. So
Okay.
what do you do, doc? Unfortunately, this implant has to come out.
Okay, doc.
So do those three tests that I told you,
Okay.
but most likely it will have to come out. Now,
Okay.
let you also ask me a question. Could it be the sinus or the nasal cavity? What I can see is the inferior meatus looks pretty good. The
Okay.
inferior turbinate does not look hypertrophied.
Okay.
And the maxillary sinus only has a minimal inflammation. I don't think it's a sinus issue.
Okay.
I
Okay.
think it's an implant issue, just
Okay.
like what the patient feels like.
Okay.
Okay.
Okay. Thank you, doc.
Okay. You take care. Have a good night.
Good night.
Okay.
Well, no, I'm still
Interesting.
on it.
Oh, okay. Yeah, you can just mute there. Okay. Next case. Who's
Next
saying?
case, professor, is for Dr. Diane Chu. Dr. Diane, would you mind unmuting yourself, please, and presenting your case to Professor Resnick?
Hello. Hi, Dr.
Hi,
Resnik. How
Doc.
are
How are
you?
you?
I'm
Glad to
good.
hear from. So,
Good
what
to
do you
see
have
you.
for us tonight?
Well, this is a 67-year-old male. He has history of high blood pressure. He had a stroke last year, and right now he's in terminal dentition, upper full denture, and on the lowers he only has his canines and premolars. I am
Okay.
planning this with my oral surgeon. I'm not comfortable on doing a full on X yet.
Okay.
But that's
Okay.
the plan to do a full on X. Right now well, I did say that he has the canines and the premolars,
Okay.
and I want to be able to present this case and be comfortable with my oral surgeon so we could establish a better relationship and try to
Okay.
get this prosthetic idea good,
Okay.
and so I could present this to him.
Okay. So just let me review this. We have an upper denture We
Yes.
have maybe 8, 9 teeth on the lower
He
that
has 60.
16.
Five,
Mm-hmm.
Okay, six
five and a half teeth, Dr.
five
Resnick.
and a half
Five and a
teeth
half.
that need to be extracted. And your treatment plan, you've given him all the options, and he wants a fixed prosthesis.
Yes,
Is
he
that
wants a
correct?
fixed
Okay.
prosthesis. Yes.
Okay. So now you would like a treatment plan so you could give to your oral surgeon, and because you're going to prosthetically rehabilitate this patient.
Yes, this will
Right?
be technically my first all on X, and then it's
Okay.
kind of intimidating, and I want to make sure
No,
I
no
have things
problem. No
right.
problem. So
Mhm.
let's go ahead. It appears that Dr. Hussein already has a wax up on this
Yeah,
case.
yes,
Yes.
sir. That's an
So
affirmative. Here is the
do
wax.
you want to explain that while you're doing it
Absolutely,
to the group?
professors. So whenever we get an Olonex case or a full arch rehabilitation case, we develop or design a digital smile design customized for this patient using the extraoral pictures as well as the intraoral scans. In this case, Dr. Shu, thankfully for us, she provided us with the lower iOS and the antagonist arch. We articulate that on exocad and developed the wax up that I think we've already shared with you, Dr. Shu, to approve
Yes.
first of all. Is that correct?
Yes, and I did like his current display for his upper denture, so I think he's at the right vertical. So I actually do like that wax up. I think it'll work well because you're also correcting the slant that he has for the left due to the super eruption of the left side more than the right.
Okay. Okay. So he has had super eruption of the alveolus. You can see that
Yes.
just with the natural teeth.
Hmm.
So what needs to be done in this place, or in this case, is a significant osteoplasty or alveolectomy during after the teeth are extracted. So it appears that they've already designed that. So Dr. Hussein, explain what that rectangle is to everyone.
Yes, sir. So whenever we treatment plan our Olin X case, we would like to share the proposed reduction plan or how much reduction are we planning on doing with the clinician performing the procedure. For that reason, we superimpose like a grain outline shaped box to our real guide software over here to plan it exactly where the implant platform are, give measurements to our clinicians to know exactly how much of the ridge are we planning on removing, and fast forward whenever we submit this case to be designed by our engineering group or team, they know exactly where to set the reduction plane based onto the approval that we achieved through our online review session, Professor.
Okay, perfect. So with that being said, they've estimated the amount of reduction. So can we see the implants and the reduction that you have?
Absolutely, Professor. Right now, the amount of reduction, Professor, is expected to be 5 millimeters of removing the patient crest of the ridge over here. And going a step backwards, I would like to present to you, sir, and everyone the proposed treatment plan over here. So we went ahead, Professor Resnick, with 5 intraforaminal implants, with the two most distal implants emerging through the second bicuspid tooth on the lower wax up setup. What do you think about this setup, Professor?
That looks good. So I like the AP spread. Is the C implant, can that go a little bit more equidistant between the B and the D, or is it anatomically, is there a reason?
Absolutely, sir. Let's take a look. So I'm going to start with the C position, Professor, where right now we've used a Zimmer implant. That's the implant you're
Yes.
planning on using. Is that correct?
Yes, the Simbi.
Perfect. So
Okay.
right now, Professor, I'm using a Zimmer implant over here, and I think I could get it in a more favorable position in between the C and the D
Yes.
position over here, sir. And I think I could push it just a tad to the facial aspect as well.
Yes. So see what happens. See, so what he did is he moved that over to the center, but what ended up happening is that C position went more anterior. So what ends up happening is that decreases any, or it increases our AP spread, and it decreases any force that does occur with any anterior guidance issues. So the question that we have, Doc, is this a male or a female?
This is a male.
Male. Okay. Uh, Biting forces, parafunction.
Uh, well, I don't know, right? Because right now he has dentures. I think
Okay.
dentures
So,
starting a
so the
good.
question is, do you go with 4 or 5 implants? I think in a male, this design, so if Dr. Hussein would take out that C implant, you'll see see how much we're cantilevered to the front there.
Mm-hmm.
So even it is opposing a denture, it is a male. So I would go on it if there is any possible parafunctional habit here that you go with this design. A option would be to take that C implant out and just go with the 4 implants. But I like where everything else is, and that's good to go. Your restorative space is going to be, can we take a look at that, Dr. Hussein?
Absolutely,
So I
Professor.
just
So
kind of explain that.
right now from the
Okay.
MUA level, sir, I'm sorry, I need to zoom out just a little bit. We've got approximately 18 millimeters of restored space to the incisive lip of the anterior tooth number 24/25, sir.
So 18 is very good. You'll be able to aesthetically make this look very appealing to him. And the prosthetic design will be ideal. So I think where Dr. Hussein has it is perfect and ready to go. And I would highly recommend, Doc, if you can go in and watch the surgery, that would be a good idea. So you can do
Um,
the next one.
can you do can you show 20 and 29, like the
Absolutely.
angulation? Because they are distal, I mean, no, yeah, I guess distal incline, right?
Yeah. So,
Mhm.
didn't
I'm
you?
planning the, go ahead, sir.
Yeah. Show with the nerve there.
So here you go.
Oh,
Yeah,
right there.
that makes me
Okay.
nervous right there. Is that okay? Like it seems
Yeah.
so
Oh,
close.
yeah. Yeah.
Okay.
You're more than 2 millimeters.
Okay.
Uh, that that nerve, you're probably about 2.5 millimeters. You're fine. You're fine on that.
And
Let's
then
look on the other side just to make sure on the other side. Yeah,
Sir,
2.5.
29.
Okay.
I think the right side was even further, Professor. Like, here's the
Yeah,
foramen.
you're probably 3 on that one.
yeah.
Yeah, there's plenty of room. That's part of the incisive canal that you're looking at. So, and
So,
you're far enough apical to where any of that pathology around the tooth isn't going to be a problem.
mhm. So this could be done all in one surgery.
Yes,
And
yes.
would this be an stackable guy?
It, that would be the easiest and the most ideal, I think. Yeah, it would probably be the easiest way to do it. So,
And
and
the
let
surgeon is planning to place like MUA uh,
yes,
abutments.
yeah. So Dr. Hussein can give you a MUA guide, and
Sure.
after they place the implants, the MUA guide just puts them right on, makes it very, very easy for that.
Yeah, I guess my question is about the restorative portion. Once he places the implants, we're planning to have the patient come to my office the next day for me to deliver. Is that
Well, you could deliver it the same day also. You could deliver it at his office during the surgery after the implants are placed. So you could immediate load it. It would still be immediate load the next day.
Mhm.
Was there any reason why you were going to do it in your office the next day?
Because of scheduling, I could really not do it in the surgeon office, but
Oh,
the
okay.
offices are
Okay.
close by, so he could potentially come to my office. I've done this a long time ago, and then it was a mess trying to pick it up with the acrylic. Is this a similar situation?
Well,
So,
oh, go ahead,
uh,
Dr.
I'm sorry.
Hussein, you
I'm
answered
sorry.
that one.
I'm sorry for interrupting, sir. So, Dr. Shu, this depends on your inventory or instrumentarium. Are you planning on doing this as a photogrammetry or a grammetry technique? Do you have access to any of these machinery? Because if you've got those, we could go with no pickup. It's going to be a conversion. But if you don't have this kind of instrumentarium at your own practice, we're going to have to send you the pre-milled restoration with the big holes that you're going to have to pick up using temporary titanium cylinders if you're planning on doing immediate loading. And if that is the case, you're going to have to do it at the day of surgery because the PMMA will be latched on top of your bone foundation guide. If the surgeon takes it out, you're not going to be able to deliver the interim restoration since there is no support or vertical height to support that temporary restoration, doctor.
So,
Okay.
so what he's saying is it will be easier the day of if
Mm-hmm.
you can do it the day of. Now, they can also make arrangements for a lab technician to be there to help out with the pickup. But that's usually how we do it. The second issue that I have with bringing this patient to your office the day after surgery, patients usually are very sensitive after
Mm-hmm.
the day after surgery. They're starting to swell. They're easily put in discomfort. So they're harder to work at. If the surgeon's putting the patient to sleep, it's even easier just to do it that same day. So if you can do that, and we don't have time to discuss that whole protocol tonight,
Right.
but if you call Dr. Hussein, he'll walk you through that whole process on how to make it easier for you on
Okay.
that
I'll
one.
try to set up something with Dr. Hussein. Thank you so much.
Okay.
Mm-hmm.
Okay. Take care, Doc.
All right. Thank
Okay, let's go. Next case. Who do we have?
Next case, professor, is for Dr. Guzak. Dr. Guzak, would you mind unmuting yourself, please, and presenting your case to Professor Resnik?
Yes, can you hear me?
Hi, Doc.
Loud and
Yes. How
clear,
are
Doc.
you?
Awesome. Thanks for a great course this past weekend. It was awesome.
Oh, good. 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 Glad you liked it. So, what do you have for us tonight?
Okay, 73-year-old male that I inherited. Really no like major health indications. He did have a knee replacement 3 months ago, so his surgeon had recommended that, any surgeries be postponed until June 15th. So
Okay.
the plan is he came in my office. He had a previous crown number 7. He's obviously had a lot of restorative work done, broken off at the gum line. So trying to figure out whether immediate implant placement number 7. I know this is one of the cases we talked about this past weekend that's kind of in that yellow zone of immediate implant placement versus removing, grafting, possible membrane, and then delaying that implant placement. So that's kind of where I'm at tonight.
Okay. Okay. So let's first take a look at a cross section number 7,
Yes,
and
professors.
let's see what it looks like, Doc. And I love it that you remember that in that yellow. So that yellow means yellow light. So to be cautious. And this doesn't look too bad, Doc. There's not much bone out to the facial, so I would say it is definitely it's a yellow light, but it's close to a green light. So what I
Okay.
do like is see that column, see that vertical line, their
Yes, sir.
diagonal line that he just. That's perfect. You have plenty of bone there. Scroll back and forth, just one click on each side. Okay, other way. Okay. Yeah, Doc, I think this will be this is a good case.
Okay.
This will be a good case. Did you plan this out, Dr. Hussein?
Yes, sir, I did. I'm using a 3.0 by 13 glide wheel tapered implant at the side of number 7, professor.
Okay.
This was
Okay.
planned a couple months ago, and then he had his knee replacement. I brought it to the course just because I knew this was what we were going to be talking about at Module 2. I know this is kind of outside of the realm of what we were talking about tonight. He came in today as well, obviously missing 14, 15. He has really poor hygiene, which is one of my kind of
Yeah,
setbacks.
that
And, you know, 12, 13 area, they're very decayed, obviously missing 14 and 15. I don't know if we can, quickly discuss possible options of, at the 12 and 13 area and even 15.
well,
Obviously long term.
yeah, so I did see I was going to talk about that here in a second. Go to the pan view.
Yes,
What
professor.
I saw right off the bat was number 4. See number 4?
Mm-hmm.
Uh-huh.
Okay, so it looks like you have a fixed partial denture 4 to 6.
Correct.
Is that correct? and 4 does not look healthy to me. So
I know.
let's look at 3 and 4.
3 and 4.
Start
Yes, Professor.
Yeah, let's start at 3 and then move over to 4. Okay, so 3 doesn't look that bad. You've had some bone loss. This is 4.
Yes, Professor.
Okay, so there is an apical lesion on it. Okay, it looked worse than the Panorex. So keep going.
No discomfort that he's noted at all.
Okay. Okay, then keep going. And then you told me about 13 and 14 or 12,
Like
13, 14.
13, like the
Ooh.
distal is so decayed. And obviously he's missing 14 and 15. I'm just thinking long term. I don't know, what the best option is for him.
Yeah, so what tooth is this?
That's tooth number 11, Professor.
Oh, that's 11.
Yes,
Okay.
sir.
So 11's a key tooth, as you know, you're discluding off of that, and there's a facial dehiscence on it.
That's number
Okay.
13, Professor, and that's number 12, sir.
Okay. So 12 doesn't look good. Let's go to the Panorex again.
Yes, Professor.
So, Doc, I don't know if you remember in one of the videos I talked about a 5-year success rate or the 5-year rule for teeth. And when we look at saving a tooth, we say, is this tooth going to be here in 5 years? If we
Right.
don't think it is, then it's a good option to take it out. Um, I'm not seeing a lot of good things here on this whole dentition on the upper. If I look, you have 2 bridges, one on each side. That the distal abutments have apical lesions and the root canal and decay.
Right.
So right there, that's a problem. Number 11, has a apical dehiscence and a lesion on it. I think what you need to do on this one, Eric, is to look at this patient and give them all the options. And there are 2 big extremes. One is trying to save the teeth, and the second is not saving the teeth and what can be done.
Okay.
And give them as much information as you can on both of them. So if I would look at saving these teeth, I would say, you know what we need to do is take periapical x-rays of each one of these, do a good perio, thorough exam, and see which teeth have a good 5-year success rate. What I'm seeing right here, you're not going to have many teeth that fulfill that criteria.
I know.
With
My
that,
worry
with
is
that
like,
being,
I'm sorry to cut you off.
oh no, go ahead.
My worry is, doing an implant at number 7, and then, he's worried about the upper left. And it's like, okay, well, if we extract 12 and 13 and, try to implant up there, it's like, all the money that's going to be invested, is it worth just, cutting the losses long term and, I don't know, doing something fixed as we talked about this weekend?
Yes. So, but the problem in this is where it gets very, very sensitive to patients, is where they don't have the information or the understanding on what it means to remove all their teeth. And
Right.
yeah, they can say, you know what, I'm sick of getting root canals. I'm sick of getting decay. I'm sick of brushing. So I want them all out. But just taking all the teeth out doesn't solve all the problems, as you know. So my high recommendation, because I see so many of these cases now where patients come back at doctors and say they were too aggressive, they should have tried to save the teeth, That's why I love to give these patients all the information and then have them make their what they want. And the 2 extremes are keep the teeth or take the teeth out. So number 1, keeping the teeth, you're still going to lose some of the teeth. You might end up with all new crowns and partials and or maybe some implants here and there, but this patient's going to be a chronic dental patient.
Right.
And they're never, you're just kicking the can down the road because these teeth are in such poor shape. However, on the other side is the patient obviously is masticating, eating, probably can eat anything they want. And when you edentulate them, they lose all their proprioception. So there's disadvantages to that. Then you go into, there's almost no bone there, doc, and all the infections that if you do edentulate them, you would have to remove all the teeth, remove the infection, graft them, and then come back. This is going to be a 2-year process to get him to where he has no bone in the posterior. So if we do try to get posterior implants, we're probably going to have to do some sinus lifts. It's going to be a rather invasive and long treatment. So some people are tired of dealing with, getting root canals and fillings and whatever. Others might say, you know what, I don't want to be in a denture. I don't want to be in 2 years of treatment. I don't want to have bone grafting. So I think what you do is take that treatment planning form that we have, you give them all the options, fill in all the advantages and disadvantages, and go through multiple consults and let him select what he really wants to do. And don't let him put it on you to make the decision, because if it doesn't turn out the way he likes, we don't want him coming back to you and saying, you talked me into this and now look,
Right.
things like that. So I'll give you my gut opinion on it. I think the best thing for this gentleman would be to remove all this and give him a removable or a full arch implant prosthesis. I think that would be the best thing for him. I think financially it would be the best, because if you kick the can down the road, he's going to end up spending a lot of money. And you were astute to say that. I love that you said that, because you foresaw that, and that's something that is really good. And just keep practicing like that and you'll be very successful. So it's being honest with the patient. So this is just a complete mess on the upper, and I think trying to fix it. Number 7, it would be a good site for immediate implant, but now after seeing the rest of the teeth, probably is not a good idea.
Yeah, and I mean, honestly, he was in this morning. I had to have a chat with him because he came in and there was just food all over his teeth. And I, gave him a mirror and said, listen, look at all of this food. Like, and, one of the
Yeah.
patients, it's 11 a.m. and he said, sorry, I didn't have time to brush my teeth this morning. Well, you invested $50,000 into your mouth and you're not brushing your teeth. So it's like, what do we do?
Yeah. Eric, because it's just like I spoke about this weekend. Patients think that they get implants and they won't have to do that anymore. But think about it. If they lost their teeth because of poor hygiene and neglect, they'll lose their implants the same way. You have to
Right.
re-educate them. And what I never want is a patient to come back to you and say, you never told me this. So put it in writing, use that form that I have. Just trust me on this. You'll
Okay.
be able to sleep better at night, and it'll alleviate so many problems, because these patients, especially this gentleman, his expectations might be a little bit more than what you think. Because again, it's the thought process out there of just getting full arch implants and, going to Ruth's Chris Steakhouse that night and eating your favorite steak. They think, and it doesn't hurt, and, doesn't cost that much. So,
Right.
they're wrong on all. So that's what I would do. I'd have them come, and then after you get him to commit to a treatment, email me and let me walk you through all this, and we'll treat this one together. Okay.
Okay. Sounds great, Doc. Thank you so much for your
Okay,
time.
Eric. Okay. Have a good night. Take
You
care.
too. Thank you.
Okay. Okay, Dr. Hussein, who's next?
Next case, Professor, is for Dr. Mary Salama. Dr. Salama, would you mind unmuting yourself and presenting your case to Professor Resnik, please?
Hi, Dr.
Hi,
Resnik. How are
Mary.
you
Hi,
doing?
Mary. How are you?
Good. How
Good.
are you doing?
Good. Good. So what do you have for us?
So I have Todd. He's 40 years old. He has ADHD and he smokes cigar like occasionally.
Okay. Did you
So
say 4 or 14? No, okay, he's not 14 smoking cigars and looking like that. He's
yeah,
40?
he's
Okay.
42.
Okay, 42. Okay. Okay.
So he came with infections, and he wants to explore his option of a lower denture. On the upper, I give him two options, but I told him based on the CBT scan, either we save 6 to 11 and we do a partial on top, or we take everything and we do a denture. The problem on the top, he has a high smile line, so I would be worried about implant retained denture. Um, that's what I feel, but
Yeah.
uh,
So, Mary, an easy way to explain this to the patient is Mr. Smith, here's the situation. We have to take out your upper teeth. You're going to be in a denture. Let's see how you do with the denture. If you are fine with a denture, that will make it very easy. We'll put implants in the lower. You'll have a permanent upper denture. If not, if you have any reservations or you're not happy, then we can explore after everything is healed how we can or what the possibilities of placing implants and the different types of prostheses.
okay.
So that gets basically that sees how the patient that allows the patient to do like a dry run on just a conventional prosthesis.
Okay.
So with that being said, I believe you said that the lower was more of the concern for
Yes.
implants. Okay. So
Yeah.
I see decay there. I see apical
Infection.
infections. So
Yeah.
these teeth definitely have to be taken out. Um, is that correct?
Correct.
Okay. So Hussein, did you work some implants up on this case?
Yes, sir, I did. So here's my trail of thought, Professor. So I planned at the A, B, C, D, E position. With the A and E position, I tilted them along the anterior loop anatomy to stay clear away from this crucial anatomy. And here's the final setup, Professor.
Okay. So Mary, he has 5 nice implants there with a good AP spread. Now let's look at them in the cross-sectional views.
Right away, Professor. So that's our first implant, sir. A 3-5 by 13 at the E position, sir. As I rotate around
Okay.
this one, here is the mental frame and here is the loop anatomy, and I'm perfectly clear away from this anatomy, Professor.
Okay.
Then we've got
So
the,
first of all,
go ahead.
let me look at a pin.
Yes, sir.
Okay, this is a type 3 nerve. Yeah,
This
come
is a
close.
type 3 nerve. Yes, sir.
Okay. Did you check for you said loop anatomy. Is there an anterior loop on this?
Here we go, Professor. Let's take a look through the axial image, sir. I'm going to go ahead and switch the bone masks for a second. Here is my mental foramen. I'm going to draw with a line. You've taught me to draw. Here we
Okay, yeah, go a little higher. Go a little higher though.
lead this one. Here we go. The yellow line.
Okay.
Perfect.
Okay. So we're going to look to see if that pink goes anterior.
Oh, I'm sorry, Professor. I zoomed in a little bit too hard and kind of moved my measurement. But yes, it was going anterior, sir. Here we go.
Okay.
One more
So,
time.
so here, just so everyone understands this again, go in the axial, but let's go superior. Okay. Now, that blue line or the yellow line, just one click anterior. No, opposite way, right there. Okay, so that's going to be the mesial aspect of the foramen. Now he's going to go in an inferior direction, and we're going to see if that line goes anterior to that. Okay,
It
so
does.
we have about a 0.5 millimeter. Keep going.
Exactly half a millimeter, Professor. Here we go,
Okay,
sir.
perfect. Okay, so maybe a little bit less than a millimeter. Let's look at the other side.
Yellow
So go
line,
a little bit higher,
sir.
a little bit higher. Right. Okay. Now, right there. Okay. Now let's see what we have. And I would say there's really not one on that side. Okay. So on the right side, we have about a half millimeter anterior loop. So you took that into consideration when you're far away from it anyway. So anyway, everyone on the call, that's how you look for an anterior loop, just like that. And you could see one side has it, one side doesn't. So good. Okay. So let's go back to those 5 implants. And let's just scroll through cross sections
Yes, sir.
one
I'll
at a
start
time.
mesial for mesial of number 20. That's number 22, Professor, where we've got the periapical pathology
Okay.
associated with that root. Here is the C position, sir.
Okay.
Is it
E,
very tight?
Yeah, that's okay. Keep going.
and that's the A position, Professor.
Okay. Okay, let's go back to the C position.
C position, Professor. Here we go, sir.
Okay. So what size implant is this?
It's
11
a
and a half.
3.5 by 11.5, sir.
Okay. So let's lower that. Keep going. Keep going. Keep going. Keep going. Now make that a 10. Do they have a 10?
Yes,
Oh, that's
sir.
a
They do.
Gladwell. Yeah,
Yes,
make it
Professor.
10. Okay. A little bit lower. Okay, perfect. Right there. Okay. Now let's go back to the Panorex.
Here we go,
Okay.
Professor.
Now let's adjust all those implants to that height. And I'll tell you why. Number one, this patient has had super eruption of that whole alveolus, probably 10 millimeters. So it's way too high. Secondly, their anatomy buccolingually is very, very thin. So as we go down more apical, we are going to have more bone availability. So he can play around with these, but also in that D position, I think the D implant can come over more anterior a little bit and inferior. And then the same there. Okay. And then those distal ones can come down a little bit. Perfect. Okay. So, Mary, are you going to do this case? You're doing this case?
I want to do this case, yes.
Yes. Okay. So I don't want you to be intimidated by the amount of alveoloplasty. It's just a little bit more than what we would normally do. But with the infection there and the anatomy of the bone there, we're going to have to sink these a little bit lower than normal, which is fine. We're going to have 5 implants, so you'll have more than enough support.
So,
You're, I don't think you'll probably have to remodify that incisal edge position for those lower teeth. I have a feeling this patient shows a lot of lower teeth. Do they?
um, I don't remember, but I know he has a high
Do,
smile line. So I
High
have to
smile line.
recheck.
Okay. Yeah, it just looks like, see, if you look at let's look at it straight on,
Right on,
Dr.
sir.
Hussein. That whole segment looks like it's really super erupted.
Yeah.
So with that being said, implants right there, I think is ideal. You could
Is
do this immediately, which would make it very, very easy for you. Because again, you would do an alveoloplasty below most of those apices. So after you take the teeth out, Mary, just do you
uh-huh.
remember how we how to use rongeurs to
Yeah.
take the gross amount of bone off? It would come off in seconds. So it would be rather easy to do, not a problem.
I did alveoplasty before. It's scary a
Yeah.
little bit, but I did this.
Yeah.
But I have questions. So with the
Yes.
implants on B, there's infection on number 22. Is that not going to be affected?
Yeah, so on Hussein, can you go that implant?
Right away, sir. Here is number 22, or the
Yeah. So,
knee
so do you
position.
see where the apex that implant we might even have to put like 1 millimeter inferior to? Okay. Right there, you're done. You're below where the infection is. You don't have to worry about it.
Okay.
Okay.
Second
Now,
question.
okay,
Yeah,
go.
go ahead. So,
Oh,
second
go.
question. If we keep his natural teeth, do I have to do a fixed option on the bottom because it's going to be stronger, or he has the option of a removable? Would you recommend if we
You,
maintain the upper?
for this particular
Yeah,
case, wait,
yes,
I'm sorry. Did you say, do you have to do a fixed on the lower, or can you do an overdenture on the lower? Or are we talking about
yes.
the max? Yeah. So if
No,
you
about
keep
the lower.
the maxillary teeth, you could do overdenture or fixed. Doesn't
Sure.
matter.
Okay,
Okay.
okay.
Uh, you wouldn't have to place 5 implants.
Yeah.
Those implants would be a little bit different. You would be looking at 3 implants most likely for an RP4 or an RP5, and then 4 to 5 implants for an RP4.
Okay. Another thing, sinking the implant this way does not weaken the, because I know what you're saying is too much more than usual, but does not weaken the mandibular. It's not gonna break on me.
Not at all. Hussein, show her how the bone is wider at the apex than at the midpoint. So
So
if you look at just go in the midline.
that's the C
So
position, Professor.
yeah, so Doc, you
Yes.
see how thin the bone is there? Now look where
Yeah.
your implant is. Look how much cortical bone you have. So that deeper into that further
Oh.
inferior in the jaw, you're
Uh-huh.
stronger just because you have more bone there.
Okay.
So
Okay.
not at all. You wouldn't have a pathologic no way. Would
Okay.
never happen. Yeah.
Okay. Thank you.
Okay.
Yes. Thank you so much.
Okay. Okay. So when you decide, just get back with me and I'll help them put the final position on those implants.
I
Okay.
appreciate that. Thank you so much.
Okay. Have a good night.
You too.
Okay. Who's our next one?
Dr. Manmode is our next one. Doctor, would you mind unmuting yourself and please presenting your case to Dr. Resnik?
Hi, Doc.
Yes. Hello, Dr. Resnik. How are you?
Good. Good. How are you?
Good, good. I'm doing great.
Okay. Okay.
Okay.
Good. What do you
So,
have for us tonight?
so we have Ryan here. He's a 65-year-old male. He is tired of doing dental work, root canals. He doesn't want any dental pain in his mouth. So he wants to take out all the teeth and he wants Onyx on both arches. He has medical history-wise, he has high blood pressure. He had some chronic back issues and he had been through a lot of pain. Therefore, he doesn't want any dental pain anymore in his mouth now. Therefore, he wants like fixed option only.
Okay.
Mhm.
So, and this patient is how old again?
65.
65. Okay. So, were you on for Eric's case that we just went over
Yes.
okay.
Mm-hmm.
So this is going to be very, very similar. So when you have a patient that doesn't want any more pain, doesn't want any
Mm-hmm.
more problems, you have to
Mm-hmm.
re-educate them because
Yes.
implants, you can still have pain. Okay.
Mm-hmm.
Not with the implants, but during the procedure, a lot of times there's a
Mm-hmm.
lot of pain and
Mm-hmm.
you can always have complications and you can have basically differences in chewing, speaking, things like that. So
Mm-hmm.
in before I would do anything in this case,
Mm-hmm.
I would sit
Mm-hmm.
down and go over this patient with the two extremes, keeping the teeth,
Mm-hmm.
not keeping the teeth, use my
Mm-hmm.
forms, put all the advantages and disadvantages in, give them all the information, then let them
Mm-hmm.
come up with, if he comes back and says, I understand there are limitations to the implants, then go
Mm-hmm.
ahead and start edentulating him.
Mm-hmm.
Edentulating patients, a lot of them respond a lot differently than what you would think. And we're seeing that more and more. Some of the quality of life studies that are coming out are showing
Mm-hmm.
people where they used to be like a fixed prosthesis was ideal, but going from
Mm-hmm.
natural teeth to fixed, a lot of them aren't thinking that. And it is a poor quality of life for some people because they can't
Mm-hmm.
speak or eat the same. And
Mm-hmm.
it's a lot of work. With that being said, let's say that he does want all his teeth out and you're going to do it. So let's first look at the upper and see what we have. Were you thinking on immediate placement, immediate load?
Yes, immediate load.
Okay. So what I want you to do is look and see how much bone is beyond the apex of these teeth. And
Mm-hmm.
Dr. Hussein's going from one side to the other. And unfortunately, I'm not seeing a lot of bone. Maybe that in the anterior is not bad, but in the posterior, there's almost none. So
Mm-hmm.
keep going. See how the apices are right up to the nasal cavity and or the sinus floor.
Yes. Mm-hmm.
So yeah, so the maxilla is not going to be a good immediate load case. Let's look on the mandible, Dr.
Okay.
Hussein, and see what that looks like.
Right away, Professor.
Okay. So again, you need enough bone, post bone, to
Mm-hmm.
place the implant to get primary stability. If
Yes.
not, what ends up happening is that you're going to be placing implants into the sinus, into the nasal cavity, or you're going to be
Mm-hmm.
placing implants with a very low primary stability with a low possibility of integrating. So we don't want that. So,
Mm-hmm.
but let's look at the lower. Looks like he already placed some implants there.
Mm-hmm.
And let's do some cross sections on those.
Right away, Professor. So here's our first implant, sir. That's number 20, or I'm sorry, the E position, a 3.5 by 13 millimeter long implant over here, Professor. I'm going to switch out the bone mass just to show you where we are.
Okay.
So here we go. Then we got implant number, the D position, a 3.5 by 13 millimeter long implant over here, Professor. Next one is the C position, 3.5 by 11.5 over here, sir. B position, 3.5 by 13 millimeter long implant, sir. And finally, the A position, a 3.5 by 13 millimeter long implant, that position, Professor.
Okay. So, Doc, where he placed these implants look pretty good. So you could
Mm-hmm.
do immediate load on the lower, not on the
Lower.
upper.
Mm-hmm.
So let's
Okay.
go over your treatment plan. So on the upper, again, we're going to say that this patient does definitely want to do this. I would do one
Mm-hmm.
arch, the maxillary arch first.
Mm-hmm.
Go ahead, take all the teeth out, remove any soft tissue, any infected tissue, then you're going to
Mm-hmm.
graft. After you
Okay.
graft, you'll put in a maxillary conventional denture.
Mm-hmm.
He will heal for about 3 months, and then you're going to take a
Mm-hmm.
CBCT. At that time, you're
Mm-hmm.
going to look at the key implant positions and then
Mm-hmm.
determine if he needs further grafting or if you can go ahead and place implants and then possibly immediate load those implants. But to
Okay.
immediate place and immediate load the same time on the maxilla is not a good idea. Now,
Okay.
on the mandible, you could do this. So on the
Mm-hmm.
mandible, I would wait till he is healed on the top. After the
Mm-hmm.
first surgery, maybe about 2 months, you could
Mm-hmm.
edentulate him on the lower, go ahead,
Mm-hmm.
do an alveoloplasty, and place the implants. You would have to do a little bit of bone grafting around the implants, but you could most likely immediate load this case, no problem. The
Mm-hmm.
lower, yes. The upper, no.
Okay.
Okay.
Got it.
So I
Thank you,
think where
doctor.
you should start is to go back. Let's have another consultation, explain
Mm-hmm.
that it's always ideal to keep the teeth. You understand, though, but to keep these
Mm-hmm.
teeth, they're going to need a lot of work and it's going to be
Mm-hmm.
continuous work. However,
Mm-hmm.
once you take the teeth out, it is an irreversible decision. You can't put them back. So he has to
Mm-hmm.
understand, make sure that you have multiple consultations and you document very well that he is well aware of all those options and
Mm-hmm.
before you start edentulating them. Okay.
Sounds good, doctor.
Okay. Let me know if you need any help on this one. Okay.
Yes, I'm sure.
Take care. Okay. Okay. Dr.
Bye-bye. Thank
Saying
you.
next one, last
Dr.
one, it looks
Dionis,
like.
Dr. Dionisio is our next case professor. Doctor, would you mind unmuting yourself and presenting your case to Professor Resnik, please?
Hi, good evening, Dr. Resnick.
Hi, doctor. How are you?
Hi, very good. How are you doing? Good to
Good.
see you.
Good. So what do you have for us tonight?
So I have an 83-year-old man with an ibuprofen and penicillin allergy. He has a history of controlled diabetes. He's in remission from prostate cancer. He has controlled or high cholesterol and a history of peripheral artery disease. Um,
Okay.
he is on Plavix along with many other medications. In the past, we've done surgery in the mandibular arch. We stopped the Plavix according to his PCP's recommendations. He although he has a complex history, he did well with the surgery on the bottom. So now he's ready for the top to be done. So
Okay.
for the
So okay. Hussein, let's look at it straight on.
Straight on, yes, sir.
Okay. Okay, doc. Sorry. Okay. Go ahead now. Tell us what the patient, have you talked to the patient about options?
Yeah, so we did talk about a lot of options before we even decided to do any implant prostheses. Um, Definitely he wanted something that would be secure to the to implants for the bottom. And then because he liked how he could function on the bottom better with implants, he wanted the top to also be secured with implants. Right now he's in a full denture in the top and he's able to eat
Okay.
well with it. But in his mind, he already is set on having teeth that are secured with implants. And initially, before I went through your course, I was doing more like overdentures. So that's what he has on the bottom. But
Okay.
this time on the top, I'm treatment planning him for a fixed implant bridge and or FD two, FP2
Okay.
with
Okay.
immediate load. And we, I, so actually 6 months ago, I had planned this case, but when I took out the teeth, his alveolar bone was in such poor condition, I just ended up grafting. So he's been wearing a full upper denture in these past six months, and he still is really motivated to move forward with something fixed.
Okay. So right off the bat, Janice, if we look at the amount of hard and soft tissue this patient's lost. So, Dr. Hussain, can you show the group what I'm talking about? The difference between where the teeth are and where the bone is. So, with that being said, an FP2 might be now you can always do an FP2 when you have this much bone loss, but aesthetically it tends not to look as nice as an FP3. So right off the bat, you said that he is wearing a denture that he's basically happy with. So I assume aesthetically he's happy with that, with
Yes,
like the
aesthetically,
fullness and everything.
yes,
Okay.
he is.
So an FP2, just for some of the newer doctors on the call, an FP2 is going to be an elongated tooth. FP1 is a normal looking tooth, clinical crown. FP2 is one that's just hyper contoured or elongated. And then FP3 is where you have the tooth and soft tissue. So right off the bat, I would say that probably the best prosthesis would be an FP3 because it would be the most aesthetic, where an
Okay.
FP2 would be just a little bit too long of a tooth. If he smile, even if he didn't have a high smile line, when he would smile, it would just be a little bit longer. So that's something that maybe you just in another consultation explain to them. And usually patients, in my experience, they like FP3s better than FP2s anyway. So
Yeah.
because it looks more natural. So, okay. With that being said, she wants to do an immediate load, immediate placement, immediate load, or I'm sorry, immediate load. Hussein, did you put some implants in here?
Yes, Professor, I did add 5 implants for the maxillary arch, and here is the setup I had in mind, Professor.
Okay.
Um,
So let's go ahead. Oh, go ahead, Doc.
so I originally had planned this already with Dr. Zayed Ali with ITX Pro. And I thought they sent the case that we had planned, but it was with 6 implants. Um, and I
Oh,
actually
yeah.
went,
Well, we're just starting. Yeah. Oh, we're just starting with 5. So don't worry about that. But
okay.
keep going. I'm sorry.
And I was actually
Uh,
wondering myself if it was too much to do 6, or if, what you had, if
yeah.
you thought 5 was
So,
enough.
so, yeah. So what we do is we start. The reason why Dr. Hussein went with 5 is because if you remember, when we look at a maxillary arch, we look at the dental arch form. And if it's a square arch form, we usually go with 6 implants. A tapering arch form, even 7, or 8 in some cases with an ovoid. So right off the bat, I believe in this case why he just put 5, right? Because we probably won't have room for 2 implants in the 8 and 9 position, and he probably can't go any further distal because of the sinuses. Is that correct, Dr. Hussein?
Yes, Professor, I'll definitely need to check the project you've planned with Dr. Zia, but the reason we went with 5 implants rather than 6 is that right now, and I'm presenting the most distal implants to start with, Professor. I've got that implant, the one I'm calling number 5. I'm planning this one along the anterior wall of the maxillary sinus. Then we've got the anterior one, which is number 6. It's got good bone all around. But starting number 6 all the way to number 8 position, I could definitely add one more implant over here. But taking into consideration the arch form that we're dealing with, I thought 5 would be fine. But we could definitely add the 6 implant if you would like that, Dr. Dionisio.
What would you recommend, Dr.
Okay.
Resnick? Because I actually,
Okay. What?
we weren't sure about that, if we should do 6 or 5, but we had room for 6 when we were planning it initially.
Yeah. Okay. So if you look at when could we use an extra implant? Let's go ahead and look at a pan view of this. So,
Yes, sir.
first of all, the patient is a male patient, correct?
Correct. Mhm.
And the patient has a overdenture opposing. Is that
Yes,
what you said?
that's correct.
Is it an RP5 or an RP4?
It's a, it's an RP, it's an RP5
It,
because it's only on 3
it,
implants,
it
but it has an overdenture bar.
it's only Oh, it has an overdenture bar, 3 implants, but soft tissue supported because
Oh, actually,
is
it's
it
an
like
RP.
AC?
I'm sorry, it's RP4, and it's only second premolar to second premolar. So there is no soft tissue
Okay.
support.
Okay. So you have an RP4. Okay. So and are you not changing that? Are you leaving that the way it is?
Yeah, he's only had it in for 3 years. It functions well. It's not failing or anything. So I don't think he would want to go through surgery right now to just, or just to change it.
Oh, there it is. Okay, I got it.
I
Okay.
buried one
So you
implant.
okay. So you have 3 implants with a bar and it's an overdenture. Okay. So with an overdenture RP4, you're going to be putting a lot less stress on that. Now, just so you understand, this might be a little bit of a problem because you're going to have zirconia against a denture on the lower. So you're going to put a lot of force on that denture, most likely wear out those denture teeth a lot faster. Which ideally, you need to explain that to the patient because what you don't want to see is that it wears out real fast, especially, do they have parafunctional habits? Do you know?
No, he doesn't have any parafunctional habits.
Okay, okay. So let's get to the meat of this. First of all, your question is, do you need 6 implants versus 5? I think 5 would be fine in this case because it is against the lower overdenture, and you're only using you only have a bicuspid occlusion on the bottom, correct?
Okay. Okay, that's correct.
Okay, so without molar occlusion, you're not going to be cantilevering off of that. I don't think you're going to put a lot of force on it. So I think 5 implants would be fine. Secondly, what type of prosthesis do you fabricate on that upper? I mean, zirconia definitely is the best. I believe it's probably aesthetically right now looks the best, but you are going to wear out that lower overdenture a lot faster. So you do have the option, even though we don't do it a lot, but you'll have enough restorative space that you could do a hybrid, which would be like a titanium milled bar with denture teeth on it for a fixed prosthesis.
Oh, okay.
Okay.
Titanium with
Then
denture.
then then you then you have denture teeth against denture teeth
I see.
and less wear.
I see. Is there any type of prostheses that I could change the lower one to that would be better in the future for a patient for him?
Well, no, because it is an overdenture and you have the best. It's just a acrylic overdenture. There's really not much you have 3 implants. 2 of them are angled. So I think going to fixed would be why was the one buried there? Do you remember?
I just from the initial placement to his like pre to like 6 months later, I noticed some bone loss, so I didn't feel comfortable um using that as part of the prostheses and then having to remove it or kind of change the whole design. I didn't think it was a good implant at the time, like good enough to be
Okay.
part of the prostheses.
Okay. So here, let me just give you some potential options here. One would be just keep it the way it is. You could use just a hybrid prosthesis on the maxilla or use a zirconia as long as he understands it's going to wear out faster. Second option would be to remove the bar on the lower, remove that implant, place another implant, and then make that a fixed prosthesis on the lower also, and then do
Okay.
zirconia against zirconia. That would be
Okay.
another option. A lot more work, but
Yeah.
another option. And again, and I think you're seeing this on multiple cases tonight, that the more that you present to the patient, the more they're going to appreciate it, the more they're going to think you're thorough, and the less liability you have because you've informed them of all those options. Even though you might not think that he would ever go for it, he
hmm
might say, you know what, I I I want something fixed on the lower. I don't want to take it out anymore. Da da da. And
hmm
you could probably do it rather easily. You could take that implant out, and there's room to the midline of that.
hmm
You could probably place another implant. Yeah.
Okay, great. Thank you.
Okay. So if you need some help with the final positioning, I think if you keep things the same, this one that Hussein has is fine, and it should be fine for you.
Okay,
Okay.
wonderful. Thank you, Doc.
Okay,
Thank you.
great. You take care, Janice. Okay.
Take care. Have a
Okay,
good night.
Hussein. Okay, thank
Dr.
you.
Resnick,
Okay.
we've got
Yes.
one last case, sir, the one we started with for Dr. Pham, if you wouldn't mind. I think Dr.
Oh,
Pham
okay.
is on the meeting. So,
Oh,
Dr.
he
Pham, are
is?
you
Is
here,
he
Doc?
on? Okay.
Hello there. How
Hi.
are
Hi,
you
Doc. How are
tonight?
you?
I'm
Okay,
good. How are
good,
you?
good.
Sorry, I
Good,
got
good.
our time
Okay.
zone mixed up.
Oh, no problem. No problem. So what do you have for us tonight?
Well, thanks for having me here tonight. I have a
Okay.
53-year-old male. We extracted tooth number 30 approximately 6 months ago. You and I had consulted on this case outside of the grand rounds, and you had given me some feedback about how you were worried about still having soft tissue or infected tissue in the site. So
Okay.
it was just a whole lot to unload. So I was just hoping to be able to discuss it with you in real time.
Okay. So, did we discuss this at one of the courses? Is
So, it was after last month's grand rounds. I sent it through the ITX Pros, and they consulted with
Oh,
you
they
and
sent
gave
it
me
to
your
me.
email back. Mm-hmm.
Okay. And I question the healing of the site. Is that
Yes.
correct?
Mm-hmm. Yes.
Okay. So let's take a look at it. And so explain. Oh, yes, I do remember this. Okay. So here's Hussein. Go very slowly and let's show the group what I was concerned about. See this radiolucent areas here? Okay. So usually when you see that, that means that there is soft tissue in between the patient's host bone and the grafted bone. And Doc, refresh my memory. What type of bone did you use here?
It was just the socket preservation that from Selvin.
Yeah. Do you remember? Was it an allograft?
Yes, I believe so.
Okay. And when was the graft done?
Probably 6 months ago, going on 7.
7. Okay. And when was this scan taken?
This was about a month ago.
Okay. And do you have any other scans prior to a month ago
Uh,
during the
that I
healing of this?
that I do not.
Okay. Okay. So the reason is we don't really have a baseline on this. So my only concern was, again, Hussein, let's go through it real slow so they can see some of those radiolucent areas right there. So what I'm a little bit concerned about, Doc, is you want to place one implant. Is that correct?
We're open to what needs to be done. The patient's very open, wanting to do what's best, but just very
Okay.
eager to get the place replaced.
Okay. So if I recall, let's go back and look at the 3D image of this.
Yes,
Okay.
Professor.
So what I believe, did we talk about possibly putting two implants in and splitting them together?
Yes, you did have that in your consultation notes.
Yes. So what I don't like about this scenario, Doc, is if you look just distal to that bicuspid, the bone does go down. It like sinks a little bit. So we're at a crown to implant ratio that's a little bit lower. Number two, we have opposing two molars. The second molar is super erupted rather significantly. So in these type of cases, what I don't like to do is just place one implant in, because then you're going to place a lot of force on that. And another, I think, better long-term solution is two implants. And even if you have to make two bicuspid sized teeth, so you don't even have to, if you can just pick up the mesial of that second molar, I think you would be good. Stress, the biomechanics would be a lot better. So with that being said, Hussein, did you place any implants in this?
Yes, sir. I did add two implants, Professor, at the size of number 30 and 31. And following Dr. Pham's instruction, I'm using a Bicon implant, Professor. That's our first implant, sir.
Okay.
Oh, we had switched
Okay.
our, since talking to you, Dr. Resnick, we've switched our everything into going back to Han.
Okay. Did I tell you to not use Bicon?
Yeah.
Probably. Yeah. It's just too difficult. The sizes aren't ideal there. Okay. So let's just go with generic 5 millimeter. You can make them. Yeah. Oh, you did switch them. Okay.
Yes, sir. So
So
here,
with that being said here, Doc, let's just look at this implant. Okay. That's an 8. Go ahead and make
that's a
that a
5 by 8,
10.
yes, sir. You got it, Professor.
Yeah, make it a 10. And let's see what we have. There we go. Okay. Now just raise that a little, one click up. Okay. Okay. Now raise it to 11 and a half and just see where we're at. That's 11 and a half.
Yes, Professor. Right now we're at 11 and a half.
And how far are we away from the nerve there?
Exactly, sir. And I'm exaggerating my measurement. It's the 1.9, so one more click coronally would do as well, sir. 2 millimeters right now, Professor.
Okay, 2 millimeters, sir. And that's within
Yes, sir.
11 and a half. Okay. Now
That's
go
with
to the
11.
10. Okay. Now take it one click inferior. One more. Okay, good. Okay. So, Doc, what I'm trying to do, just one more click.
Yes, sir.
Okay. Sorry about this, Doc.
No,
Okay.
you're
Now, how far are we away from the nerve now?
we've got plenty of space, Professor, right now, and I'm taking it from here. We've got 2.7 millimeters of vertical height. It's a little bit more, Professor, but I'm just seeing it on the broader thing, like on the broader spectrum of the diameter.
Okay. So then give me one click inferior.
Yes, sir.
Okay. So that is 30. Is that correct? Number
3 millimeters
30?
away. That's number 30. Yes, sir.
Okay. Leave that one. Perfect. Okay. Now let's go to number 31.
5 full by 8, Professor.
Okay. That looks good. And how far are we away from 30 and 31?
More than 3 millimeters in between those two implants, Professor. Right now, we are at exactly 4.4 millimeters mesodistally, sir.
Okay. So let's bring that a little bit closer. Make it 4 millimeters. So
Sir.
just bring it half a millimeter anterior.
Oopsies, I'm sorry. I actually increased the nerve. Here we go. 4 millimeters right now, sir.
Okay. Okay. So, Doc, you still with us, our Doc?
Yes.
Okay. So, this, if you would say, Randy, what's the most predictable, best treatment plan? I think right there, that would be ideal. What I did is I had him reposition that implant in 30 to where any of those radiolucent areas that we showed you will be obliterated once you drill into that site. So what you would do is you would under prepare this by at least one burr, both of these sites. And I think that you would obliterate that. Secondly, the implant, the apical end will be in host bone. So you'll be below the socket. So you will get primary stability there. So our only other option would be is to go back and to remove all that bone and then regraft it again. After looking at this again, I think you're going to be all right if you prep and place the implants right where you're at. I think you'll get good primary stability. You can splint these two implants. The only thing you're going to have to do is do a enamelplasty or modify that opposing second molar so that you have enough space. But where we have placed the neck of the implant, it's going to give you more space anyway from the crest of the ridge. So I think we have 4 millimeters between the implant. You're 2.5 away from the adjacent teeth. If you splint those together biomechanically, they're going to be very strong. And I think that um, where that bone did not turn over into host bone, I think you'll be all right there. The worst case scenario is when you prep the number 30 site. If it's very, very soft and it's just you're not getting any stability, then you could always just regraft it. But I would go in with the expectation you're going to place the implant. You just tell the patient if you don't believe that the bone is strong enough, you're not going to place the implant, you're going to regraft it. Okay. And if you do regraft it, then what you would do is go in and decorticate it and go ahead and puncture so you wrap it so that you increase the blood flow into that area. Does that make sense, Doc?
Yes, it does. So you're
Okay.
saying you would try to go in and prep it and see what kind of bone we have before you decide to,
Yeah, so this is what I would plan this case out that um I think after seeing this now the whole scan, I think that you can prep a lot of those issues that I had brought up before out. So as long as you encompass it within the implant, then your burr will get rid of any of those areas. So I think because we're going to go apical to that, we're going to get in the primary to host bone. That's going to give you primary stability. However, you always have to have a plan B. Plan B would be where you're going to have to graft it and, wait. So I would go in with the expectation that ideal, if everything's perfect, you'll place 2 implants. If not, you would graft that front site or regraft it.
okay. And then that's another 6 months of healing before
Yeah.
checking.
Yeah. 5 to 6 months. So if you can do this, and I think you'll be all right. After looking at all the cross sections, I think you'll be all right.
Okay. And with us being newer to implant placement, you would still feel confident for us to try this?
Okay, is this your first case?
I have one other one that I planned with you last month. That would be my first case. This would be my second.
Okay, this is probably not a good second case, to be honest with you. I would probably say you need a couple more under your belt. This is just, I'll tell you why access is going to be a harder problem
Okay.
with this because you're so far in the posterior. Um,
Then would you go the route of grafting and just buying more
then,
time?
then you could go the route of grafting, and definitely that would be an option. Yeah. So
Okay.
that is always an option because of those radiolucencies. The easiest thing is Mrs. Smith, your bone did not heal strong enough to place the implant. I'm going to add more in, and you go ahead and redo the socket grafting and wait 6 months. Just get down to the apex. You have to make sure that you get down and remove any of those radiolucent areas.
Okay.
Okay. So if this is only your second, I just think this one would be more difficult. What was the other one that we talked about
It was site number 13 and site number 30, and you had said do 13 first and then
first?
place
Okay.
30. And then she had one on 19 that needed to do tenting and screwing and grafting. So you were gonna talk me through one patient, 3 implant
Okay.
sites. Yep. Mm-hmm.
Okay, perfect. So 13, definitely do that as your first case. This one you definitely can do, but let's get some more under your belt.
Okay.
So let's just keep treatment planning them, send them to me, and we'll get you through this. This one, if you want to regraft it, that might be a better idea than trying to place the implant.
Okay.
Yes.
If I were to regraft it,
Okay.
when would you suggest rescanning and sharing those images with you? Would you do one that like at 3 months and one at 6 months?
Do a 3 month and share it with me at 3 months.
Okay.
Yes. Okay. And I'll tell you what, to make it even better, after you graft it, take a quick scan. So you have just a quick scan of that, meaning a high voxel, not a lot of, you just need to get a baseline on it so we can compare it to that 3 month one.
Okay. Sounds good. Thank you, Dr. Resnik.
Okay. Okay. You take care. Have a good night.
Thank you. You too.
Okay.
Perfect.
Okay, Hussein. Well, again, thank you. The great cases. Again, please get your cases in early, as we had a lot of people that were on the waiting list. So make sure that you get in early, and you should have received a schedule for next month. But with that being said, thank you to Dr. Robinette. I saw him answering a lot of questions, and again to Dr. Hussein, who does a great job with this. So thank you, and everyone have a great night. And let us know if you have any questions.
Thank you,
Take
Professor.
care.
Thank you, everyone.
Okay. Bye.
Bye-bye.
Goodbye.